hospital with us, Toronto, University of Toronto, and we're going to go ahead and get started. We're going to present some cases, and then Dr. Lewis is going to join us virtually from Toronto. So Dr. David Davis, one of our fellows, is going to present some cases. And actually, today we're going to discuss deformity. So we're going to discuss adult deformity, how do you do it, MIS, open, stage, posterior only, all the different approaches. So Dr. Davis, welcome.
All right, thanks so much. I'll get us kicked off this morning. I have no, let's see, are my slides coming across for you?
Not yet.
There we go.
Perfect.
Thank you. I have no relevant disclosures related to this presentation. A little bit of history on this gentleman. He's a late 60s-year-old male from Alaska, has multiple years of severe back and leg pain, highly motivated individual, and he had suffered a fall from multiple stories that correlated with the onset of worsening symptoms a couple of years ago, but had multiple years of discomfort, did more than adequate care, non-operative treatment attempts, but continued to decline in terms of his ability to function. You can see his Asian motor scales below showed weakness in bilateral hip flexors and knee flexors, no pathologic reflexes or myelopathy. When we look at his scoliosis films, we can see significant thoracolumbar degeneration, some loss of lordosis, and then some segmental kyphosis as well. And so we've also included here, let's see, some advanced imaging with a CT myelogram to be able to better view the pattern of his injury. Intraoperatively, you can see that we made the decision to do multiple levels of intradiscal osteotomies to correct his deformity, as well as a T9 to pelvis fusion. Postoperatively, here's his scans.
So David, just go back to the original films. I think this is an important part of the discussion. I think, Jens, this is your patient, is go back to the original scoliosis x-rays. So I think, again, yeah.
Oh,
right
sorry
there.
about that.
So I think, for us, I think this is one of the important things about doing deformity surgery is be able to do the measurements. But also, I think more importantly is, which patients get surgery, which patients don't get surgery. And then, you do a big deformity surgery on someone like this. The bone marrow on this patient doesn't look good. It looks like they have is that a pseudoarthrosis of their clavicle fracture, or is that fused?
Yes. It looks like notice pseudo. It was definitely, probably had a non-union.
So, was this patient, what's the metabolic condition of this patient?
Yeah, he had a history of cardiac problems, but was medically cleared almost immediately. And again, definitely.
And how about bone density? What's the bone density of this patient?
I didn't measure it. I'm sorry.
So those are important, factors, when deciding to do big surgery. And again, just from my perspective, when you look at a case like this, obviously a CT and MRI will give you a lot more information. But, just looking at this, the sagittal bounce doesn't look bad. The coronal bounce is a little off. And what was the, when you said the patient had extensive non-operative therapy, what does that include in your analysis? He was
with the Alaskan Native Coalition, so I didn't have all the notes, but okay. I was under the impression that he had significant therapy. And I'm not entirely sure if he had injections or not.
But those
hey, Rod.
Want to look at, yeah, Jens.
Yeah. So first of all, the slides are apparently not coming across. I actually see the slides, but there's a commentator who says that they're not coming across. But this is my patient, and we actually followed him non-surgically for 2 years. But this is, again, one of those problems when we have geographically diverse coverages. he was sent to us, and I think I saw him once 2 years prior to the surgery. And we had very limited abilities to actually do things, but he got like 2 or 3 sets of injections. He got a brace. He got a PT referral, which he actually did. And this is a very active guy. He's actually a fisherman, and he actually works the clavicle fracture. This is a very astute observation of yours, the reflection of his high grade activity level, which obviously plays a role in this. But all the things you're mentioning are very good, but we did not jump on this patient who's going to be really following for 2 years.
Yeah, I know. I'm sure he had extensive. I was just trying to put David in on the spot. Just in terms of, if you look, I think he's got pretty significant. I think he had a pars fracture, grade 2 spondy. If you pull up the CT scan, I mean, these are difficult cases because I don't think you can just do a 1-level fusion on this. And then if you do 2, and then now you've got that junctional, where he's got some coronal imbalance at L2-3. So these are difficult cases. Do you just end it at L2, or do you go up to, where do you end a case like this? Because it looks like he's got some, coronal imbalance there, kind of in the apex.
Yeah, I mean, obviously, I'm cheating because I've already shown the post-ops, but you can't stop. You can't stop at the thoracolumbar junction here. You clearly got to go to the pelvis with that spondy at 5-1. You got multiple level spondies, so you got to go at least to T9, T8.
And then Jens, what's your feeling on, he's got a pseudo there on his clavicle fracture, and his bone density doesn't look great. So,
the bone density. Yeah, the bone density actually turned out to be superb. And I don't know what the Hounsfield units were, but the intraoperative also had tremendous bone. He's a non-smoker and actually was not taking alcohol, but he had a past history of alcohol abuse. But he was an avid non-smoker. The biggest concern we had is he's from a geographically remote area, and he has a good tribal support, but he does not have a great family support. He lives by himself. But he's a outdoor person, and I thought in my one physical visit with him that he was actually a great and very engaged patient. We have Dr. Lewis on. Stephen, good morning. So this is a geographically remote patient. He's in his early 60s, I believe. He has some heart condition, but non-smoking, non-alcoholic. What are your thoughts in terms of surgical optimization and considering a patient like this for surgery? And do you do less or do you do more? Stephen, you might be.
Maybe Jens, let's show the post-op films.
Okay.
And then let's show the CT, I think. And Jens, how did you decide how high up to go on this case? I think you're muted.
The question was how high to go, and that's a very good point. We felt that we should go to about T8 with a junctional instrumentation. We're very pleased with the intraoperative bone density, but your cavities, we did an open reduction of the spondylolisthesis, so we did a full release, a full RDO, and did an active short segments translational correction, put spaces in there, and then took the hardware up to about T8, and we did a 5-level interbody fusion to get maximum coronal and sagittal correction. So, so that was our intraoperative strategy. But we felt we could get enough fixation rostally to the junction kyphosis to not let the fall apart. So,
how high did you guys end it? Was it T8 or okay?
Yes,
T8.
Sir.
Okay.
Yes, sir. If you count on a little bit of the formatting translation, but just that top right image you can see is not overlapped correctly.
Yeah.
But
yeah, I mean, I actually saw this patient on rounds, and he did great.
Yes,
unlike most of these patients, he used minimal narcotics. I think, as Jens, as you pointed out, I mean, this was a very stoic person. I think the L5 radiculopathy on this patient is, to me, it seemed like that was his main issue. And you guys got a beautiful correction, especially at the bottom. If you can just show that last CT, I think he had a grade 2, almost 2.5 or 3 spondy, and you can see the reduction that you guys got. Was that a bilateral T-lift that you guys, IDO there, Jens? Oh yeah, he's on. He's
Yes,
on the
sir.
plane.
It was bilateral at 5.1.
great.
Here's a better.
Is there a coronal? There we go. Okay, so bilateral at 5.1, and then unilateral at the other levels. Yeah, I mean
So
these are
for
difficult.
neuromonitoring, we actually, we did not just MEPs, SCPs, and EMGs. We actually did direct nerve root monitoring also. We had a probe, and I'm always worried in this isthmic spondylis about causing a silent L5 radiculopathy. So we actually measured the L5 root impedance with a separate probe before reduction and after reduction. So, and there were no real changes to it. But I tried to assess not just physically the tension of an L5 root, which is completely released, but also the impedance, and I would take away some of the reduction if it was decreasing. But we did not have it, so we left it in place, and fortunately it was fine. I'm not sure if Dr. Lewis is live now. Is that a sensible modality to use, this direct root monitoring for vulnerable roots like L5 during a reduction?
Yeah, I mean, I think L5 is always tricky, and you can have normal neuromonitoring and still end up with a foot drop. So, excellent. Thank you, David.
Thank you.
So, fantastic. So I think we have, is it, Brian, are you loaded? Okay. So Brian Anderson, one of our fellows, is going to present the next case. And again, the topic is adult deformity. And I think, in my practice, and I think probably in Dr. Lewis's practice, Steve, are you on yet? Is that, these are very difficult patients. They're very difficult cases, but they can be extremely rewarding because most of these patients have a pretty significant amount of pain, but also a significant amount of deformity. And I think, those are extremely difficult patients because it's very small. To do a small operation on a deformity patient is not easy. So Brian, go ahead.
Yeah, good morning. I don't have any disclosures. I'm going to present a patient very quickly. Her name is, she's a 74-year-old female with a 3-year history of progressive decline in her gait and her hand dexterity, also with sensation in her upper extremities. No focal weakness, but she does have this gait instability, which is really what brought her into the clinic. No history of spine trauma, surgery. On exam, she has multiple long track signs. And her past medical history is really not significant. You can see on her exam on the right here, she doesn't have any focal weakness, but she does have several positive long track signs. Here is selected slices of her MRI and CT. You can see on the sagittal MRI with the axial cut that she has multi-level spondylotic changes, with her tightest level being at that C4, C5, C5, C6 with about 4 millimeters available for the cord. And then on that sagittal CT, you can see she has that kyphotic deformity, most prominent at C3, C4, with near complete destruction of her disc joints at the below levels. So really briefly, 74-year-old female, she has a neuric grade 4 unstable cervical spondylotic myelopathy. You can see her flex X films right here. So I think this is all common to us, but we've got a few treatment options. We can watch this and understand that there's going to be this stepwise decline with her presentation the next time we see her. We could choose to do this from the front only. We could restore her height in an attempt to restore her height and get somewhat of a decompression from the front. We could try to maximally correct her deformity from the back, or we could do them both. We could do them both in a stepwise approach, or we could do them both on the same day. with this particular patient, we presented her with all of those options, and she decided to go from the front, from the back, and to try to do it in one go if possible. So that's what we did. We did C3 to C7 ACDF with allograft, a C2 to T2 instrumentation and deformity correction from the back. Case was really uneventful. She got a primary closure, a couple drains, EBL was 300. The only problem during surgeries, we did lose motors to her right deltoid, and that was during the flip to prone. Her postoperative course in the hospital was a little protracted. She had some encephalopathy that resolved by the time she was discharged to a SNF. But at discharge, she had 4 out of 5 deltoid on the right and 3 out of 5 on the left. Here's a CT, just her postoperative CT, showing some of the correction here. Let's see if this plays. It's pretty brief. Again, you can see the allograft very well positioned. She has the restoration of her lordosis and the height, and then she has this C2 to T2 construct posteriorly with excellent purchase. No issues with screw placement, particularly at that C5 nerve root level.
So,
Sir?
This is an excellent case. And I think one of the things that is common.
Rod, microphone.
Yeah. Just walk in. So the C5 palsy is an issue, and you know, it's not uncommon to get these, and I would say that looking at her preoperative scan, I'd say the chance of having a C5 palsy are about 99%. And I think you guys did an excellent correction. Jens, what do you try to do to prevent C5 palsies? Is there anything that you found beneficial?
This is a extreme frustration for us. And this case I thought was really helpful because we did have a change in our modus after we had turned her prone. So from the anterior side, we try to not over-distract. We try to be very measured in our C4-5 of this type restoration. Still, I thought we had not done anything cowboy-esque. We did a release, we did anterior column restoration, but nothing traumatic happened. And then we turned her prone. We did have a decrease in the motor signals. We had high MAPs, so MAPs of above 85. We actually gave her Nascus 2 steroids. I don't remember whether the industry planned or not, but we decided to then proceed with the surgery because overall everything seemed to be trending right. But the motors were correct, and she did have a deltoid weakness in the end. And it took her almost half a year to get over it. She had no sensory problems, she had no pain. For posterior surgery, I try to do wide feminotomies preemptively nowadays because one of our fellows did a great study on the jack and showed that this is most likely a traction phenomenon. And this would also fit to the proning of the patient. And we do use temporary shoulder pull down, but we release that the second that we have the hardware placed. So we did that in her case also. Nonetheless, I think we still had the problem from the overall height restoration. So I'd be curious to hear other thoughts, but this is a temporary frustration. It fortunately is totally resolved, and she's extremely happy now. And I feel it's resolved her myelopathy also. But it does show how sensitive and how when you use neuromonitoring a lot, how helpful it can be. I'm not sure what I should have done differently or if I could have totally avoided it. So I'd be curious to hear your thoughts.
So, yeah, I mean, I think for me, you know, even if you look at the C5 nerve root, there's not a lot that I think decompressing it, you guys got a beautiful realignment. It's just one of those nerves where, I think the teaching was somehow the C5 nerve root has some funky anatomy and all this stuff, and none of that turns out to be true. The reason why I think people get C5 palsies is because it's clinically more evident. It's the only nerve that goes to your deltoid, so when you knock it out, you can't function without your deltoid. And more importantly, it actually is the main nerve that goes to your biceps.
Yeah.
So you lose biceps and deltoid. And, that's why we call it a flipper arm, because you literally can't do anything with your arm. But the old thinking, Jens, was in neurosurgery, they always talked about this, how it has this unusual anatomy and it's a special nerve, but it's not. It's just clinically more noticeable.
Right.
And I think you guys did a beautiful correction. I don't think there's anything you could have done, Jens. I mean, that was, you freed it up, the framing looked great. You decompressed it. And usually in my experience, they almost always come back. It just takes time. And, the reason I said there were 100% chances, what are the risk factors? Myelopathy, kyphosis or deformity, and then the patient had prolonged surgery. And, they're going to get it. I think you just have to, as you guys did, decompress the nerve and be sure that that's not being compressed. I think if it is compressed, then that's another issue.
Right.
But I think you guys, Jens, that was a beautiful reconstruction for a very difficult case. I think, I'm not sure you need a plate in this case because you're going to go in the back.
Right.
So I think if you were going to stage it, probably plate it. But I think Jens and I don't think plate.
So, quick comment there. So first of all, Cliff Pierre has a very nice 2 articles that he put into the chat room. So for all of our visitors around the world, look at those articles. Thank you, Cliff, for putting those in. Dr. Mark Kukowski asked us always a very insightful question: what was the swallowing status? So I give a high dose steroids, and she actually went through a period of a steroid psychosis. So we had talked before about possibly putting a peg tube into her. She did not want that. But we put an MG tube down her for feeding to control her because she was in the hospital for about a week, correct me if I'm wrong, or 10 days, Brian. But we put an MG tube down her, a Dobhoff tube, to supplement her feeding, and then she has completely normal swallowing now. So, but we talked about that when I do these significant deformity reductions, I usually tell them about putting a peg tube into them beforehand. Brian, any thoughts?
Yeah, I think swallowing is an issue, and I think the C5 nerve root palsy. But I don't, I think I try not to. I think you can, if you think they're at high risk, I think it's a good idea to get a peg.
Yeah.
But I try to get in and out fast. That's another reason not to put plate on. The more time you spend with that retractor open, the more risks there are.
So, for my limited,
Yeah.
she was very high risk for the C5 palsy, and she was counseled preoperatively extensively about the different options, the risk factors, and especially about the C5 palsy. So it was something that was known going in. The good news is that her 1-year follow-up, she remarkably, somebody that was pretty advanced myelopathic signs, she's walking unassisted, has a great gait pattern, and has complete resolution of her bilateral deltoid palsies. So,
Great.
yeah, she did very well, as you can see on the slide right here.
Yeah,
Yep.
Terrific.
And this is her 1-year follow-up showing great fusion. Thanks.
Great case.
Thanks, Mark.
Our next presenter is Dr. Neil Patel. And our theme this morning, again, is deformity surgery. We just showed a nice scoliosis, adult deformity, and then now we've got Brian showed us a nice cervical deformity. So Neil.
Perfect. So my goal was to kind of round out the conversation with MIS case and deformity of the MIS. So I have a 54-year-old gentleman who presented with low back pain and a sensation that his ribs were touching his pelvis, and this sensation was worsening. He had history of 5 years ago getting a L2-3 laminotomy for disc extrusion, and you could see his pictures from 5 years ago here with the L2-3 disc, that side with significant, that was causing him significant pain and issues. His exam was intact, in terms of his motor strength, he was intact, and his reflexes were two and had no other clonus or hyperreflexia in the lower extremities when we saw him. He is a stay-at-home dad now, but he used to work in gardening and was pretty robust and hardworking and things like that. So he had good bone density. He was young, 54, no diabetes, no hypertension. 9 years ago, you could see he had gotten a CT scan for abdominal issues. It looked pretty straight on the AP, on the CT scan. And we saw him 5 years after that, or 5 years ago, and he had about L2-3 laminotomy done. And these are his images immediately post-op. So he already was starting to develop some L2-3, 3-4 disc disease and unilateral disc disease and some scoliosis. At 6 months ago, it had worsened, and now you could see his ribs touching his pelvis completely. At that time, we also counseled him about scoliosis repair or reconstruction and long segment fusion, et cetera. And then we got him pre-op CT where you could see L2-3 and 3-4 vacuum disc and a significant curve on his scoliosis. So these are his pre-op CT images. And again, you could see there showing through sagittal and coronal images with pars, that 2-3 there, which is intact, but it is the lower level is digging into it a little bit, and that's causing his scoliosis there. And you have these pre-op images for him, and then we got also an MRI scan that again shows no significant disc anywhere other than that one 2-3 level, which was resected earlier 5 years ago. And he had no pain symptoms from that at all at this moment. He just had that sensation of his ribs touching his pelvis. He wasn't able to stand up straight. He wasn't able to do his gardening work, so he became a stay-at-home, and he was taking care of his 4 kids. So we brought him to the operating room and we staged it. So this is XLIF stage 1, where we did 2, 3, and 3, 4 XLIFs. And we got nice cages in, and this procedure went without any issues. And you can again see his correction just from the XLIFs, and he straightened out significantly, and everything else became really mobile thereafter. After which we did MIS percutaneous fusion. And that also went without any issues, and you could see significant correction of his scoliosis with a 2-stage procedure there. These are his post-op CT scans, again showing the 2 cages extremely well placed, a center covering both end plates and placed anteriorly to give him some more lordosis as well, and the percutaneous fusion without any issues with the hardware. So pre and post, you could see we saw him post-op 6 weeks, and these are his images from post-op 6 weeks from pre-op. He's very happy. You could see his ribs are away from his pelvis now and almost parallel to the other side. He's able to stand up straight. He's working with physical therapy. His pain and posture have significantly improved. He's considering maybe going back to work. He does have some left hip flexor and knee extension weakness, which is very well known from XLIF, but he does have good control of muscles, and he's able to trigger them. It's just that he has had some atrophy, so he's working on getting the strength back, and he says it has improved significantly over the last couple of weeks, and with physical therapy, it continues to improve. So we expect him to have good recovery and back to work in the future.
Great. Steve, I don't know if you're on yet or not, but you know, in my practice, obviously everyone's different, but I do a lot of laterals, and you know, the plexus is always an issue, and this guy developed some weakness post-op, and he actually was weak before surgery. I don't know if you guys saw that L2-3 level, but it was pretty collapsed.
Yeah.
And so, you know, and he progressed pretty significantly. I saw him a couple times in the last several years. In fact, I did his laminotomy 5 years ago. And it's incredible how much he progressed. I wish we had a scoliosis x-rays, but he went from having, like a minimal curve to like a 75 degree curve just from the apex down. And, he, again, very fit guy, very active, doesn't smoke, wasn't a chronic pain patient. He actually did great. We staged it. And we did stage 1 and then stage 2, we did it MIS. And the tricky part with doing these MIS is always, sometimes you can put an S1 screw in, sometimes you can't. And then a lot of times I bring these patients back and do an ALIF just to make sure that we get a fusion at L5S1. But almost always, we put iliac fixation. And if you can show, putting the, and again, this was done percutaneously, trying to connect that the distal end of this construct can be very tricky. And so you can see we kind of lined it up there, but you really have to line it up. And you can see the rods, basically, we pass the rods up, and that can be challenging to do because you don't want to pull your screws out. So there's some tricks that we do to try to, get the rod to seat down, and it's always in the apex. And then this guy, we had pretty good purchase, but you can see the spine literally, while we're putting the rod down, you can start to see the rod pull the spine back over. And, the correction's not perfect, but I thought we got pretty good correction. And again, I like doing these if I can in stages. And then I think MIS, in my experience, getting this thing to fuse. So we decorticate the facet joints. We typically what we do is we decorticate and then put our screw in. But getting a fusion and then putting the rod in, and obviously, in the past, fluoro used to be an issue. This was done with some navigation, so that's been a real game changer. But I think one of the advantages to doing MIS is less blood loss, and then my rate of PJK is almost non-existent. And I think it has to do because we're not exposing the other levels.
Right.
And so you've kind of created a soft landing inherently. So any other questions or comments? Jens, I think you're probably already taken off.
So we're about to take off, but this is beautiful, Rob. And again, I'm a skeptic about MIS, but this is as beautifully done. And if you can read out Dr. Dekutowski's reduction suggestions and comment on that, Rod, that was a very clever statement of his. You preempted my main question, Rod, and that is, how do you fuse the spine when you have percutaneous screws and rods? How do you actually get a true facet joint decortication? Because that's my main caveat. And then in my practice, I see a lot of non-unions. They do well for about a year or two, and then everything is kind of windshield wiped. So those are my questions. But if you'd read out the reduction thoughts by Dr. Dekutowski and Chaplin, I think the public would be interested in hearing.
Yeah, I mean, those are excellent points, and we try, just like an open surgery. I literally, and Neil was there, with navigation, you can actually, you can see the facet joint on navigation, and we just drilled it out, you remember?
Right.
We just drill out the medial part and then put allograft in there. And so, just like you would do an open. Again, I think, with navigation, it's gotten easier, but it's still, these are very challenging cases. I wouldn't recommend that you go out and do one tomorrow. This has taken me 15 years to get, and what's interesting is the companies all, I've used all the different systems. They all suck because most of these sets are designed for open surgery. And then all the companies do is put these tabs on. They put extended tabs on them. And so that's not, the instruments aren't designed for it. I think you were there, we use kind of a mixed bag of instruments from open and even the rod holder, it's laughable because it's not designed for, it's designed for 1 level MIS. It's not designed for, 7 or 8 levels. And then,
Hey, Rod, quick question.
yeah.
One of the things I've struggled with in doing multi-level, I've never done a T10 to pelvis MIS, but it's easy to kind of hook on the wrong side of the fascia when you're passing that longer rod. What are some tips that you have for avoiding that?
I mean, that's excellent question, Amir. You can, and in this guy, I didn't, but what I've had to do in the past is actually do a midline incision. And then that way you don't have 20 stab incisions. And then you can get the fascia, you're right there, so you can open the fascia. I think that's the best way to do it. The problem with, and you pointed this out, is that, it's getting the rod and making sure that you're in the right plane and all those different things. So I think opening the incision midline and then doing, stab incisions through the fascia, that's probably, I'd say, the easiest. But then usually what ends up happening is you still have to make a separate incision for the rod, because usually the rod is rostral or caudal to where you want to go. Like in this case, we had to make a separate incision just to get the rod. And then I use, there's a little instrument. It's basically, it looks horrific, but basically it stabs the fascia. And so you're able to create a plane in that direction to get the rod started.
Yeah.
So, and I wish we had a picture of, intra-op versus post-op. I mean, it was remarkable. I mean,
Yeah.
you can literally see the spine shift
yeah.
after we put the first rod in.
Yeah.
So, but you have to be careful because the bending of the rod before you place it, how much stress do you put on the apex? Because it's really easy to pull these screws out. And if you pull the screws out, you're kind of screwed. And so I typically, again, like that was a 5.5 titanium rod.
Right.
So you just have to really be careful, and the bending has to be absolutely pristine. And so what we do is we check, you can basically, there's a little instrument you can do to check the curvature to make sure they're all aligned. So before I put the rod down, and Neil was there, like every single screw was like basically almost perfectly aligned in order to get the rod to sit down. So.
Hey, Rod, do you have Mark Dikutas? He's chat. Here's a chat on the kind of cool, some tips and tricks also to augment what you just said.
What was Mark's question? Do we know? Okay. Let's see. Yes, so we did slipping osteotome through. So we actually did a lateral at L3-4 because I felt like we could get some correction, Mark, yeah, I mean, these are great comments by Mark. Obviously, both Mark and Mark's done a lot of percutaneous approaches. And I've never done a 3-rod construct. And I think, obviously the muscles, the ligaments, the fascia, all these things are very important. And I do think rod insertion, I think Mark's points about, this is exactly the way I think about it. I mean, these are all considerations. Where do you pass the rod? Do you start proximal? Do you go distal? And Mark points out, I mean, the most difficult parts of these cases are trying to get the apex. Like in this guy, it was L2 to L4 to try to get the spine to push it back. Yeah. And so, I do some cantilever rod contouring. And then I really try not to, I do decorticate the facet joints. And then again, I think staging it and going lateral, it's very difficult to get these coronal curvatures to do it. If you did it all posteriorly, I mean, I think, in my experience, it's a lot more challenging.
Yeah.
You've got those facet joints, they're all subluxed. And so I definitely try to stage it. So great. Thanks, Neil.
Thank you. Do you think the new beds that kind of turn coronal angles would help with better correction? I mean, this was easy.
Yeah, they help.
Yeah.
I think all those, I think any of these, any of these adjuncts that have come out in the last 5 years are super helpful. So I think anything you can do to give you that 5 degrees makes a huge difference. So thanks, Neil. So we've got our last one will be very quick, and then I think Dr. Lewis, are you on yet?
Yeah, I'm on.
Okay,
Yeah.
great, awesome,
Yeah.
Steve. I don't know if you saw the last case, Steve, but we presented. We've been presenting.
I saw that. I'm
Okay.
jealous. That was a beautiful correction, and I think you did an incredible job. And I agree with. I was listening to everything, so I agree with the philosophies that you did. And I know there's a big trend towards multiple rod techniques, and yeah, I'd be interested on how. I think the big advantage of MIS is you don't have the dead space that we have in open surgery. And the dead space is a huge barrier to fusion. You just don't have the same muscle against the bone. And I think it's one of the things that we've been struggling for. And I agree with you, like PJK, pseudoarthrosis are big problems that we have that perhaps the MIS gap can fill in better just without the dead space. But, I agree, getting fusions are either intraarticular or extraarticular. The intraarticular through the facet joints and the disc is where you have to target most of your bone. And whether, I know you decorticate your facet joints, I'm not sure what you're putting in there. Like me, open, I put structural bone into each of my facets, preserving them nicely to try to get the posterior column. We usually, supplemented with an interbody, but I definitely have, we go back on our cases and there's a lot of dead space around and really muscle that's really not conducive to having a nice fusion where the blood supply from the bone comes. So I'm not sure if the 3-rod that we need is as important with you. And I'd be curious with your MIS experience, how much pseudoarthrosis you have as well, even with your anterior column, and whether multiple rods is as important in MIS as it is in open.
Yeah, I mean, definitely for us, Steve, I think I've tried to, I think there was the thinking, 5-6 years ago, even, like stiffer rods and, trying to get, I think I've kind of gone the other way. I'm trying to get a rod that's has a little bit more give in it and is more physiologic. And again, I don't know what it is. I do think the muscle preservation is a huge thing. And I agree with you. I think fusion, and then again, I've never used multiple rods for these MIS cases because it's just so challenging just to get even the 2 rods in. So, but those are excellent points. So Gautam is going to present one more case, Steve, and then we'll be excited to hear your talk. So Gautam Rao is going to present one more case.
Appreciate it. Thank you. This is another case presentation that we've had for deformity that we've actually had a 2-year follow-up on. So interesting to take a look at the intraoperative monitoring and the deformity correction and how she's been doing in the past couple of years. No disclosures. This is a 64-year-old male at the time, or female at the time, with back pain and claudication as her primary symptom. She had a history of nicotine use, and she had seen our clinic a few years before, and we had recommended cessation, which she had completed, and then we were able to do the surgery on her to optimize her as much as we could. This is her Asia score. The NT is just not tested. In the lower extremities, 4s, 4-, mainly pain limitation. Reflex is intact with no long track signs and no dermatomal strict dermatomal pattern for numbness, just kind of overall numb. The plan for her, given the extent of deformity that we had, was a 2-stage procedure. First stage was a L3 to 5 XLIF, followed by the next day a T3 to pelvis instrumentation with multiple interbodies. Intraoperatively, in the first case, there was no monitoring changes in the XLIF portion. And in the T3 to pelvis, after the deformity correction, there was a decrease in the left-sided SSEPs with no change in motor potentials without really any reason per the operative, no real change or immediate cause of the incident. The post-operative ASIA score had some hip flexor weakness on the left side, which is expected due to the left-sided approach of the lateral, and that did improve over the next few years. These are her scoliosis films preoperatively. As you can tell, she has a severe coronal and sagittal imbalance. That's pretty dramatic. These are her lumbar CT scans, as well as her thoracic, and this is the supine CT scan compared to her standing that shows this pretty profound deformity that she has that is able to reduce on the supine position. So the first case, we did the 2-level lateral fusion, able to get the interbodies at 3, 4, and 4, 5, followed by the pretty dramatic T3 to pelvis, multiple level interbodies, quadratic construct with pelvic fixation, and T3 hooks, TP hooks at the top for a soft landing in order to minimize any future adjacent segment disease. This is her 2 years post-op, so this was actually maybe a month or so ago. She has some loosening of the TP hooks, so with some protrusion of her hardware, but overall alignment is very intact. And here's the comparison from pre-op to the post-op imaging. It's a pretty dramatic correction. And again, 6 months post-op, excellent return of function and mobilization, able to kind of do the things she was able to do before. In 2 years, doing well without much issue. She does have some worsening kyphosis, mainly due to postural instability, kind of her overall nature rather than any hardware malfunction. This is a recent review article published a few months ago, actually, looking at the intraoperative neuromonitoring scoliosis surgery literature in the past 10 years that essentially said most deformities have maybe some sort of intraoperative monitoring changes, and that's typically due to when the deformity is corrected due to the stretch of the neuropraxia, as well as this does return typically just kind of vary on the time frame and the severity, very patient dependent. But just interesting that this patient had a left-sided SSCP drop during surgery, and fortunately post-op didn't have any significant clinical consequences.
And Gautam, can you go back to the original scoliosis x-rays? So Steve, I don't know what your thoughts are, but Camptocormia is comes to my mind, and or maybe did this patient have also potentially like Parkinson's or
not through the chart review? I think it was only the Camptocormia that you're mentioning.
What do you think, Steve? I mean,
I agree 100%. I think I thought for sure there's from the x-ray I thought maybe it was ink-spawn looking at the thing, but then clearly on the CT it is not. And I think this is a classic Camptocormia, and usually very high on the differential is Parkinson's. So you may have some sort of non-Parkinson neuromuscular disorder, but it's not the usual for someone with a small deformity to stand in this position. So
what would you guys do in Canada? I know you're a pediatric surgeon, but...
No, I do both, actually. I do both. So.
Oh, you do both? Okay, great.
I do mainly adult, actually.
Would they, I think, in the US, obviously this is a controversial case. I think I know what our health system would want us to do, and the insurance companies. But
we can't kill everybody, so we actually fix those too. So
yeah. So what do you think, Steve? How would you manage someone like that in Canada?
So we usually get a neurology assessment. We try
Okay.
to maximize the medically, look for any other issues. And then I think you're going to deal with some junctional issues and some pseudoarthrosis, and it just goes with the territory. And I
Yeah.
usually just do a posterior, T2 to pelvis. I think half the correction is on positioning. It looks like in this, maybe a few, most of the deformity seems to be at the thoracolumbar junction. And maybe I think I can just get away with a few Smith-Pete's through there. And then I would do usually just some posterior interbodies, probably 4-5 and 5-1, maybe 3-4, depending on the disc spaces and stuff. But that's kind of, we don't have time. I have almost 300 people on my wait list, and it's hard to dedicate 2 days for one patient. But, I do tolerate a few pseudoarthrosis in that sense. But I try my best for this one, probably get a double rod at the bottom. A lot of my colleagues like to use the kickstand rod to try to push them over, putting a third rod that would go from more on the iliac wing to push them over on the side. But I would do something similar to you, minus all those interbodies in the front. But I mean, this is a beautiful correction. And I think you had, there's junctional kyphosis on top. It's kind of expected for this. And I haven't had luck with hooks or screws, or it doesn't matter what I use on the top. I think everybody breaks a little bit on the top. You just can't help it.
Yeah.
I was actually expecting a drop head deformity at the 2-year mark, but you didn't have one.
Yeah. And then how about, what do you do, Steve, for rods? And then what also do you do for fusion? Because there's so much, like you said, I mean, they're all going to get a little pseudo either distally or proximally.
So I preserve every facet joint, and I put structural bone in every joint. So I burr each facet joint out, and I harvest every spinous process that I can, and any lamina, and they save them as big pieces, and I impact them into each of the joints. Usually we don't have a lot of money for BMP on our cases, but that would be one that maybe I would consider at the high risk areas, which for me are at the top and the bottom of the fusion. And I would use an extra rod in the lumbar spine, like is done. Usually I do it through 2-headed screws, just because I find I don't like to use the connectors, which usually sit over the facet joints. And so I like the dual-headed screws, and I'll just pass a second rod on through those screws. So I do a similar construct, all posterior though. And again, I use the biggest rod. I'm a 6.0 cobalt chrome. I use the strongest rod I can. And I use it as a cantilever. So I'll contour the rod in the desired plane that I want and the correction I want. And I try to bully the spine to my rod with the tubes and things like that. So.
And then Steve, how about for interbody? What do you do? Expandables, allograft, peak?
Yeah, we only have bananas and straight. So, and I use all metal. So I like, I don't want to advertise for any company, but I like the titanium ones that go in. We fill them in with some local bone that we put in the bone mill, and I pack bone usually in front of the cage as well. So.
And then how about for your interbody? Do you do like a full release at each level?
No, see, I preserve the facet joints. So they're all P-lifts. So
Okay.
I do not. I think maintaining the posterior column is really important for fusion. And so I wouldn't rob the back to pay the front. So. I do these kind of preserve the facet joints, do P-lifts. Often they're, you like to do them on the concave side. The convex side, you have a lot more room for some of these cases. So, and the banana shaped cages I find hold a little bit better, but they're a little more difficult to put in.
And then how about, I know you're going to give an excellent talk on some of these issues, but when you see a case like this, like you said, I am automatically say, okay, this patient's going to get PJK. What are your tips or tricks to avoiding getting PJK or drop head syndrome in a big case like this?
I mean, the only thing, like the one that it's in your hand is fusion and alignment. And I think those are the two that you really have control over. And you can maximize this patient, but this one's not going to the gym before surgery. And there's only so much you're going to be able to do with his bone. So if there's things you can do with the bone before surgery, then that's great. But I just kind of, successful surgery means you meet or exceed their expectations, and you just have to set the expectations appropriately. That this is unfortunately, you got a bad problem, and I'll do my best to fix what you can. And then I would have thought that you'd be up to C2 by now, but credit to you that she's still holding out strong. So,
And then how
but
about,
I really focus on alignment and fusion as my two things that I can actually control.
and then how about Steve, in terms of, I know, again, you're in Canada, we're in the US. How about from a health system perspective, when you're talking about neurology, and then we always have a hard time trying to get, someone to manage these patients, like whether it's the primary care doctor, everyone, it seems like the immediate thing they do is they go, okay, it's like a hot potato. Everyone sends it over and literally tell the patients that the only option is surgery. What do you guys do in terms of when you said we try to get them to maximize? What does that involve? Because in the US, I try my best to try to get, but nobody wants to see these patients.
I think even after COVID, it's even harder. I think everybody wants to do remote, and so I'll do the basic workup. For me is make sure they're cleared for their heart and lungs. I'll check their bones. I'll image their spine and get anesthesia involved. We do have a medical consult service, and we have an osteoporosis doctor that we work closely on some research projects. So she's kind of helpful for us. And our neurology department has a very strong movement disorder clinic that they're interested in helping out if we have someone. So, but you're right, you do have to have a system where you're supported to be able to provide the other cares.
And then how about the economic impact of a case like this? Because, I think, we're under more and more scrutiny. And I don't think people really realize that the impact of this surgery on that one patient. And it's not like we do a lot of these, but I think in the US, if you look at the pie graph and all the, fusion has just gone crazy. And so,
Right.
we're under a lot of scrutiny. And I'm sure you guys are in Canada as well.
Yeah. No, we have problems that we're actually, they don't pay us for the surgery. So we've been kind of fighting back a bit. So like they took over a year and a half to pay me, like for my 2022 surgeries for deformities. There was 30 that hadn't been paid for over a year and a half. And
Wow.
so I stopped doing them for a while, and then the place went crazy, and I had to go on television and explain why we're not doing them because the patients were all complaining. But it is a problem, and everybody's broke now. We have a one payer who's broke, and debt and high interest rates make their debt even worse. And they're really kind of cutting back on what we're able to do. So our hospital has a limited budget. They promote us to do 1-level fusions and 1-level decompressions, for which the government gives us a bonus. And the rest of our work of these kind of cases comes out of our global budget. And the hospital's pushing us to do the smaller cases. So it is a problem. But the patients are stuck. And, I probably will do at least 1 a week or 2 a week of these. So it has a big impact on our budget, and I spend a lot of time with the administrators.
It's funny, we're having the same exact problem in the US, and all the hospitals are pushing for doing these smaller surgeries where they get higher reimbursement. But when you're in a big center like ours, both Jens and I have a list, and unfortunately, these cases just don't pencil out. And the reimbursement's just not there. So thanks, Gautam. So with that, Steve, we're gonna go ahead and I'd like to introduce you to the group. So Dr. Stephen Lewis is a orthopedic spine surgeon. He's head of the spine program in Toronto, does mainly deformity surgery, both pediatrics and adult. He did his fellowship in the US at Washington University, and he's published tremendously in the field as a well-known leader. And both Jens and I really admire you, Steve, especially for what was going on. We know what was happening in Toronto. And it's great to see that you stood up for what is a very difficult problem, you know, it's not just in Canada. Trust me, I think this is a global problem, and these patients are really are at the center of what we do, and we really applaud you, and we're excited to have you here. So welcome.
Thanks a lot. I think my favorite text out of all that was from Jens, who just said one word, and he wrote communists. And so it was, and I don't know if I could say it much better, but and I
mean, literally, Steve, Jens and I are talking about this. When you're going through your stuff in Toronto, we're facing the same exact problem where, you know, we have patients literally hunting us down in the hall.
Yeah.
You know, in the Starbucks, you know, cafe, I mean, everywhere, they're just everyone's like, what's going on?
Yeah. And then they complain about you to the hospital and to the college, and they say, please operate on you, you know? And I mean, so it's kind of an interesting way of doing business, but
yeah,
I do feel bad for them. And that's why we've started back on doing some work. So thanks. I am actually going to give up my pediatric practice just because I can't do it all. And that's probably by the end of the year. But in the meantime, I'm doing both pediatric and adult work. And we've done a lot of work on neuromonitoring. And we have a study going on that which hopefully will be published pretty soon on the results of a multi-center prospective study on looking at deformity surgery and neuromonitoring. So I'd like to, I think understanding and managing the neuromonitoring issue is something that is kind of difficult to understand. And I'm going to go over some of the principles that we use so that we can get the corrections we do. We look at basic neuroanatomy, the blood supply to the cord today. We'll go over some of the injury patterns that are very common, the neuromonitoring modalities we use, and then how to correlate the modalities with the injury patterns we're seeing. There's checklists, and we'll go through what I really break down into traumatic versus perfusion-based changes that we see. So how do you take, this is a 16-year-old boy, we did this, we had a lot of significant changes during surgery, but we're still able to have a happy spinal cord and a nice correction. And how can we do all that and really interpret the changes we have and how to manage them? So we'll start at the basics, and we'll start with the neuroanatomy. At the start, there's really, for us as deformity surgeons, really have to look at three tracks. There's the dorsal columns, which are ipsilateral, light touch, position, and vibration, and they're in the back of the cord. And then we have two in the front of the cord, which is the corticospinal tract for motor, which is ipsilateral, and the spinal thalamic, which is pain and temperature, and it's contralateral. And if you know just three tracks, that's kind of how things are set up. And then in terms of the way the fibers go, for the anterior tracts, the cervical are going to be medial, and the sacral and lumbar are more lateral. And that kind of gives us this central cord syndrome that we see, where the upper extremity are going to be more involved than the lower extremity. And then if you go on the blood supply, the blood supply to the spinal cord comes through branches off the aorta. There's the intercostals, and they bring off the segmental spinal artery that brings segmental medullary vessels to the spinal cord. The main segmental medullary artery will contribute to the anterior spinal artery. And then there's two posterior spinal arteries giving a pretty good blood supply to the back of the cord. The front of the cord, though, through this single anterior is a little bit more precarious. We often have a main artery called the artery of Adamkiewicz. It usually comes out on the left between T8 and T12. And if you did an angiogram at that level, what you can see is that it has this hairpin loop, which is classic for the thing. The other thing that's important to understand is that the blood supply actually comes in with the nerve root to get intradural. So cutting a lot of thoracic nerve roots may be impairing some of your blood supply. So the way it reaches the spinal cord will be through the nerve roots coming in. So let's go over some of the patterns of spinal cord injuries, which I think is really the important part to understand. We're looking at really, everybody knows there's been well-described injury patterns that we see in the spinal cord. There's complete spinal cords, central cords, anterior cord, and posterior cord. So we'll go over some of these. So the complete cords are quite, you're going to lose your corticospinal, your spinal thalamic, and your dorsal columns. That'll be bilateral. The central cord, you're going to have changes in all three of these as well. When you get to an anterior cord syndrome, this is the only one that's really pure perfusion. It's all ventral. It's a problem with the perfusion from the anterior spinal artery, and you'll knock off your corticospinal and your spinal thalamic tract with your dorsal columns preserved. The posterior cord syndrome is more common for either posterior-based tumors or iatrogenic from putting a kerosene or a wire in the canal where you hit the back of the cord and you lose your dorsal columns, but the other tracks are preserved. And then the Brown-Séquard, which is a hemi injury to the cord where you get an ipsilateral corticospinal, contralateral spinothalamic, just the way the fibers are desiccated, and an ipsilateral dorsal column injury. So if you break them down into perfusion versus traumatic, the anterior cord is the only perfusion-based injury. The other ones are actually traumatic injuries to the cord. So a different mechanism of injury and perhaps a different injury, a way of monitoring and looking at it. So then we go back and say, okay, during surgery, what can we test? Well, we can do our MEPs, motor voc, we do our SSEP, we have EMG, we can do wake-up tests and a clonus test, which we check. And then what are we actually testing? So when we do an SSEP, we're actually only testing the dorsal columns. It does not do the spinothalamic. And the spinothalamic is not directly measured, but it is indirectly measured through the corticospinal, the MEPs. And because any drop in the MEP will reflect the anterior cord, the spinothalamic will be reflective of any MEP changes. And then we have EMG, which we use for our nerve roots. And so it's important that you understand that the anterior cord syndrome will be the reflection of the anterior 2/3. It's a perfusion problem, and it requires, if you're going to do your monitoring, TIVA, so total intravenous anesthesia. So if you do have them with the wrong anesthesia, you will not have your motors. And the motors are actually stimulated. You have to press a button, otherwise you don't know what's going on. They're not free run. So you have to communicate often with your tech to press the button to check and see what kind of signal that you're having. For your posterior cord syndromes, you're kind of looking at the SSEPs for your dorsal columns. They're really good for direct injuries. For posterior column or for complete cord injuries, you'll see changes on both. But we see them in laminectomies, intradural tumor resections, sublaminar wire, hook implants, things where the back of the cord is at risk. So how do we correlate these changes with spinal cord injury patterns? And that's what I'm going to go over today. So what we're going to do is we look at MEP, which will look at our corticospinal and our spinothalamic tract. That'll be our perfusion based. And then you have your SSEP, which will be your dorsal columns. And you'll see that in injury patterns often. So if we look at what to expect during surgery, these are, again, the syndromes, and how do we interpret them? So if we have a bilateral loss of MEP and SSEP, well, our differential now is going to be either a complete cord injury or a central cord injury. So things like where you just closed your osteotomy, you pinch the cord off, you may have some sort of central cord injury, but this is a traumatic event to the cord that you're seeing intraoperatively. Then if you have an anterior cord, you're only going to see MEP. The SSEPs are going to be perfectly preserved, and that's a very important piece. So if you have isolated MEP, no SSEP changes, you're looking at a perfusion-based problem, and that's how you're going to have in your differential. Your posterior cord, MEP is going to be preserved, but this time you're going to lose your SSEP. And then in your Brown-Séquard, it's interesting, you're going to have ipsilateral motor loss and ipsilateral SSEP loss because the spinothalamic tract is going to be recorded only through the MEPs. So there's checklists that go on, but the checklists are pretty good. It makes you think about a bunch of things, but it doesn't actually tell you what type of injury you're dealing with and whether the loss is MEP unilateral, bilateral, including SSEP or not. And that's kind of one of the biggest problems when they call this checklist problems. We wrote a paper on looking at neuromonitoring changes during 3-column osteotomies. We broke them down into 3 types, whether it's prior during the decompression, prior to the decompression, like positioning and things like that. 2 would be during the decompression, and 3 would be when you close the osteotomy. This was the basis of the new classification and checklist that was come out recently with Michael Vitale organizing and Larry putting the final touches on the paper. A little more confusing. It has the one which are pre-incision or post-incision. So these are things that happen before you're actually doing much work. The type 2s are going to be during your decompression, either A, during a posterior column, and B, through a 3-column osteotomy. And then 4, you're going to be, then you have these 3s that are after the osteotomy closure. And then 4, perhaps delayed, either in the operating and the surgery is kind of over and you're losing signal, or in the intensive care unit when the patient stops moving. So these checklists are okay. They give you kind of some guidance. They mix all the alerts together, so it's not specific for a type of injury and perhaps doesn't give you the feedback you need to be able to be more nimble and make your decisions. It mixes your 3-column osteotomies, your non-3-column osteotomies, and each of them should have a different profile of changes. So the checklists are okay. It makes you think about a bunch of things, but I'd like you to be more specific on thinking about exactly what's happening and relating what's happening during your injury patterns to what you're going to be doing about it. So kind of when the fire alarm goes off, you have to decide, is it real or not? And so we have this you have this change, and I break it down into kind of 3. So is it a traumatic event to the core that just happened? Is it an ischemic event to the core that just happened? Or is it something else like technical positioning, anesthesia, too much drugs? Some of the leads came out, things where it's really not related directly to what the surgeon's doing. And then you have to look at it. If my direct trauma, I'm looking, is it a central cord? Is it a complete cord? Is it a posterior cord? Is it a Brown Séquard? And then if it's an ischemic event or perfusion problem, am I seeing this isolated? And then so you kind of would act accordingly. So if you just hit a Kerrison against the cord, well, you take that off. So you have to reverse the cause. You can relieve any pressure if there's still ongoing impingement and consider steroids or other things. The ischemic one is really where you have to increase your blood pressure, try to get your perfusion. I often find in deformity surgery, anemia is one of our biggest factors, and that needs to be reversed and addressed as well. So when we look at a direct trauma, we're looking at, you have a decrease, you have a traumatic event to the cord. So I'm just showing an example of a screw in the canal. So you can see, obviously you have ongoing compression, you got to take that screw out. And the other one, the screw's already out, there's really not a lot more you can do. And so you have to really rule out, is there any ongoing compression that needs to be addressed with these techniques? And so if you break it down into these perfusion versus traumatic, I find the traumatic can be unilateral, bilateral. It'll be MEP, usually with SSEPs. It'll follow some sort of traumatic event that happened. Whereas the perfusion ones, you may say, I didn't do anything, what's happening. You'll see only MEP, the SACPs are preserved. It should be bilateral because it's from the anterior spinal artery. It may have a delay, the right faster than the left, or vice versa. And often happens after you did something like you just put the rod in, maybe you've had traction going on, the blood pressure has been too low, or the patient's quite anemic. And really, a lot of the literature on motor evoked potentials and things that's been on cervical results, and the cervical spine doesn't have a lot of blood loss, which is much different from what we see in deformity, where blood loss is a big problem. So when you see a bilateral MEP drop with intact SACP, you're going to be thinking of how can you improve perfusion. Maybe you have to take your rod off. Do you have to increase the blood pressure? Do you need some blood and some oxygen? So those are kind of the things that we're going to go. And I'm going to hammer it down with a few case examples. So here's a 16-year-old, healthy. He's got a decent sized curve. You can see this is, we were doing Smith-Peterson osteotomies or Ponte osteotomies through the apex. You can see in these, the cord will be shifted over to the side there. And we put our Kerrison in, and we had a drop in our MEP. And so this was, we have a drop in our MEP and SSEP unilaterally in this case. So we feel the compression is not further ongoing. We relieve the pressure because the Kerrison's out. This is kind of the tracings that we saw. So you can see right away, we're doing the Smith-Peterson. You can see the unilateral drop. So the right's intact in red, the blue, the green shadowing shows a drop in the motor in the lower extremities, pretty near complete. And we have a corresponding left-sided drop in the SSEP. So this is looking at it. I have an ipsilateral MEP, ipsilateral SSEP, and this really goes nicely with the Brown Séquard syndrome. So we probably have this Brown Séquard. And then looking at it, probably from the Kerrison, there's no ongoing compression, and all I can do is hope I didn't hit it too hard and that it'll come back. And so usually we relieve the pressure, make sure the blood pressure, oxygenation, and consider if you want to give steroids. In our experience, you can see that we had a gradual increase in the signal. So the blue is the left side. You can see some signal starts coming back within about 10 minutes, and it gets stronger and stronger. And then the SEP changes, you can see the changes, and then we started having some recovery coming back as well. So we had a bad 10 minutes, but the patient came out nice, and we're able to continue on with the surgery and get maximum correction for her. Here's another one, a 21-year-old female with a large curve, a double major curve, quite stiff. She's a pretty healthy girl. So we just, things were cruising along. We did our Smith piece, we put our rod in, and you can see we just lost bilateral motor. So, and the SSEPs are perfectly intact. They tried to raise the blood pressure for us, but not much happens. And so this is a perfusion injury. We have bilateral MEP. SSEP is perfectly intact, so we don't have really an issue on that. And we're thinking that this is a anterior cord syndrome with a perfusion type problem. So we tried, first thing we did is we took our rod off, and when we took the rod off, we got some signal back. So it's kind of like holding your head underwater, and you just have to make sure you didn't hold it for too long, and then get the rods off. Now tension's off. Increasing the blood pressure didn't work. So then we took the rod away, and then all of a sudden we got our signal back. The hemoglobin came back at 75, so we transfused the patient, gave her a couple of units of blood, waited for the cord to fully recover. As you can see, it's recovering nicely. SSEPs were rock solid the whole time as expected. And so this was a bilateral MEP loss, SSEP at baseline. This is a perfusion injury. This is anterior cord syndrome. And so the cause for here is anemia with correction in combination. So we took off our correction, we gave her a few units of blood, and then we're able to put the rods back in, and he had no issues after. Once we got a nice hemoglobin, we keep it over well over 100 during the case, and we had no issues, and she done very well with the surgery. Last case I'm going to show would be an osteotomy. So this is a patient who had a previous anterior and posterior fusion. So he's got a rock solid spine from a congenital scoliosis. Very unhappy with his deformity. So we were cruising along. We did releases, apical release for this patient, and things were fine until we closed the osteotomy. And we closed the osteotomy, we lost bilateral MEPs, and we had a loss in the SSEP as well on both sides. So we lost after osteotomy closure. So now we're looking at either a complete cord or central cord syndrome. So this is a traumatic event. We undid the correction, so we relieved. So there's no ongoing compression anymore. So we released our rods. So as soon as we closed the osteotomy, we had to change. We opened up the rods right away, let the spinal cord breathe, and hope for the best. So now we got rid of the compression. And you can see we start getting a little bit of signal back, but not a lot. Then we figure out why, so did we have enough bone resected? Was the cage not big enough? And we adjusted our resection to make sure that we had enough resection going on here so that the patient, and then we're able to close the osteotomy. We did not gain full motor, but we had signal bilaterally in his leg. SSEP started to improve as well. And we had signals on both sides, a lot better on the left than the right. And fortunately, he had it in a week. He was walking, and at 3 months, he was fully neurologically intact. After surgery, it was the correction that we ended up accepting for him. And we had a reasonable result for him. He actually, 10 years later, I did another osteotomy for him, and everything went fine. So we wrote our paper on neuromonitoring changes during 3-column osteotomies. We divided them up. This one is our type 3 change, where it happens after osteotomy close. So you can increase the blood pressure, give some steroids, see if they improve. In our case, 2 of them improved with those methods, 4 did not. Of the 4 that did not, we opened up the osteotomy, removed the cage, we checked what was going on. We made some adjustments, and all 4 had signal and improved. And these are the 4 results we had for the ones that met these specific criteria. And we also wrote about our perfusion versus traumatic spinal cord changes in our pediatric group, undergoing non-3-column osteotomies, showing similar findings with algorithms that we hope to reproduce on our new global international multi-center study. So I think at the end of the day, multimodal intraoperative neuromonitoring is needed to detect these changes. The SSEP is really useful, really for traumatic type events, very good in hook and sublaminar wire construct. MEP is really important for what we do for perfusion, and you're not going to pick up a perfusion-based injury without MEP. changes correlate with spinal cord injury patterns. It's kind of clear. These patterns have been described for years, and trying to interpret what's happening, the events that happened at the time of the surgery where you had the changes to the patterns you're seeing is really important so that you make the right decisions at the right period of time. Thanks a lot.
Steve, that was terrific. I think, especially for that, can you show that one case again on that kid? So when you put the rod in, you lost the motors, right? So, or did you lose motors and SSCPs on that one patient?
Do you see my screen or?
Yeah.
Okay. On this case, is this the one you mean?
Yeah, you don't have to show that, but what was your sequence? Maybe just talk about your sequence, because that's very common. Where you put the rod in, and then 10 minutes later they go, oh, we don't have any signals now.
Right, and so that's what you have to isolate, whether it's signals or is it just motors. You see, and if it's motors alone, that is perfusion based. And so usually it's because you've done a lot of work and they're a little bit of anemic, and then this correction plus the anemia are not a good combination. And so for those, I try to give some blood. If we have some self-saver, we'll throw it in and see how it goes, maintain the blood pressure. And if that doesn't work, I'll pop the rods off, and then we'll get our hemoglobin over 100, and then we'll try again. If, however, you also have an SSCP change, that is different. And if you see an SSCP change, I would say a high thing in the differential is that you may have a screw in the canal. And then when you corrected it, you may have pushed the cord into it. And so if you have an MEP with an SSCP, your differential has to change. And so now I'm looking at compression post rod insertion. Did we move that cord into something that's in the canal? And so I would take that as a different state. Same thing as take the rod off to check. But then if I have my SSCP changes, I'm going to run, an O-arm spin and make sure all my screws are not in the canal and that everything is clean.
I mean, typically, this is what I was going to say, Steve. Usually what happens is you lose the motors, and then it's almost, again, I mean, in my experience, obviously I don't have as much experience as you do, but it's so hard to get the motors to come back.
That's because your anesthesiologist won't give a unit of blood. Okay.
Yeah.
And that's why you'll never get it back.
Yeah.
And we have so many cases like that, and we've kind of changed our protocol.
Yeah.
The hemoglobin's 80 or 75, it's fine, but it's not fine for that correction. It's not enough hemoglobin for that perfusion. And then as soon as they give phenylephrine, now you're cutting your blood supply to your spinal cord even more because it's 2-alpha. And the spinal cord is not considered an essential organ. And so the more phenylephrine they're given and the more epi they're given, the less spinal cord perfusion you're getting. And so what we do is we back off, we take the rod off, and then I make them give blood. And then it's a miracle. You can just put the rod back in and everything is fine. That's
amazing. Because so like on that case, how long did you wait until the blood was all the way, like after the patient got a unit?
So I make sure I get them over 100, and I wait till the signal's back to baseline. So,
but you wouldn't put let's say the patient got 2 units and the motor's still not there, then would you, but SSCPs are there.
Yeah, I take the rod off. Is the rod off?
Yeah.
Yeah, I haven't had that. So if once I take the rod off, unless I waited too long, you know what I mean? Like I have a permanent perfusion, because you're basically creating an angina attack to the spinal cord, and you don't want it to become an input. And so, I usually don't wait that long. So, we'll try and see, but I know that as soon as I take the rod off, I'm going to be back to normal. And so I probably have about 20 of those cases like that.
Yeah. I mean, this is what this talk you just gave was very insightful, because it kind of goes over all the different scenarios, and thinking about it anatomically, Steve, I think is really important. And as you said, I think the key thing for me is there's no collateral blood supply. So the only way to fix the problem, as you said, is you just have to get blood and try to get the maps up if you can. There's really no other way. And I think, again, just because of I think this is the problem that we're facing. And I think trying to think about that and just make it very simple. And perfusion is the main goal.
Exactly. Yeah. I agree. And there's only 3 ways you can do it: is stop stretching the cord, give blood, or give blood pressure. So
Yeah, but I like your algorithm, which is like give blood, and then like what's the downside to giving blood? Very little. Right?
I know, but you'll find that it's really difficult to get your anesthesia on board, and you have to plan with them. So
yeah. And there's some great comments in the chat, and I 100% agree. Both, I know our group here and multiple groups around the country really appreciate the work you've done in this field, and really put a spotlight on, not only identifying that this is a area of clinical significance, but something that you can actually act on in the operating room that makes a huge difference. The seminal work that you guys have done in those recent papers you guys have written, I've read all of them and they're phenomenal. And I think, it's amazing. We do have all this data, and it's frustrating as hell when you're doing these cases where, you lose signals, and you're like, oh my God, how could that happen? And to have it's almost like an algorithm, here's the steps you do, and they're real. I mean, when you lose motors on a case, it's the most unsettling, information, but I think you can also look at it as, look, it's an opportunity, you can change things before you get out of the OR. And these events are real. I mean, there's no question, and I know you're in your practice. I mean, when I lose motors, it's like, oh my God, something did happen, because it's so sensitive.
yeah, but I think it's so important to be able, as someone said, you have to check them often after every, when I do all my concave screws, I'm checking after every screw, for example. So I know if I have a problem with each one, and every major step you need to do, check your motor so that you can actually time when the event occurred. And I think that's very important. I think that was one of, I think Sam mentioned, and I agree with that 100%.
Yeah. And then just to close out everything, so when you're doing these cases, is there a map, or do you use a blood pressure, or is each case different? And then how do you get the anesthesiologist kind of thinking in the same mindset as you? Because they think sometimes differently.
Yeah.
They're like, well, I checked the hematocrit and it was fine.
Yeah. So, I mean, I try to keep their blood pressure at their baseline, because I don't think, if you're doing a 14-year-old kid and you're trying to get their map at 85, it's just never been there, and it's really difficult. And I find they end up giving either too much fluid or too much phenylephrine or things to maintain it. So I try to keep them more at their patient's baseline, and only on the high risk parts. I'm more on blood than on blood pressure, because I think it's I'm not going to be able to keep their blood pressure up after surgery, and I like to know that that they're going to have a good base, that they're going to be stable after. So and you have to work hard as a team. I mean, if you have a good anesthesia team that you work important, I have a 95-degree curve today. I'm going to expect some changes after the rod insertion. May need you to give blood, have it in the room, and all that is very helpful as a team. So we have our huddle at the start of surgery. We go through some of the issues that we're going to have today, and then we try to go from there.
And then how about post-op? Is there a number? Do you keep them in the ICU? Do you give steroids? Is there a map that you're trying to keep?
I just keep their hemoglobin. All the high-risk one, I don't let their hemoglobin go under 100 after surgery. For if I was struggling with their MEPs all case, their hemoglobin's not going to go under 100 for me.
And do you keep them in the ICU? And what do you check the blood count every 4 hours, or?
No, well, we have a kind of a step down unit, and I find if I put them in the ICU, I have no control over the care the patient gets. So I try not to, unless they have some medical reason to be there. Our step down unit, at least I have full control over I can't get someone to give them a unit of blood at 85 for someone that just don't get it, or 8.5. So.
Well, Steve, thanks again. And
Thanks for inviting me.
this was a tremendous talk. And I know Jens and I would love to have you come out for our deformity course that's every fall.
Okay.
So we'd love to have you.
Yeah, I'd be honored. Yeah, thanks so much.
And it's awesome. We always learn from, great speakers like yourself, and really appreciate all the work you've done in the field. So thanks again.
Okay, thanks so much. All the
Yeah.
best.
Take care.
Okay, bye.
Bye.